I have the pleasure of introducing Zul Surani, who's the Director of Community Outreach and Engagement at Cedars-Sinai Cancer Center. It's a highly collaborative, engaging, and capacity building expert with 20 years demonstrated success in developing and leading community outreach and engagement for health system, cancer centers, and universities. Zul has extensive leadership experience in building and documenting research-driven outreach infrastructure that meets NCI designation guidelines. He has demonstrated excellence in providing strategic leadership in community-based outreach, research with populations experiencing disparities, and managing NIH-funded research, grants, and center. So please welcome my friend and colleague, Zul Surani.
Thank you so much, Myra. And it's a pleasure to be here today. And I'm going to talk about how our center at Cedars-Sinai, the Cancer Research Center for Health Equity, along with our community outreach and engagement core, is addressing inequities in different communities, different populations. And this kind of builds upon what Dr. Hayes Bautista talked about, the disconnect between the health system and communities that are experiencing cancer disparities. So what I'm going to talk about are some strategies that have worked and we've seen results. Sorry, I'm just trying to. So our Cancer Research Center for Health Equity was launched about 2.5 years ago. And Cedars-Sinai saw the need in the community to address cancer-related disparities. And so we also developed our COE, our Community Outreach and Engagement Program, which is embedded within our Cancer Research Center for Health Equity. So we really work symbiotically with our investigators, our behavioral scientists, epidemiologists, and investigators that have experience in community-based participatory research. And really our approach is, to develop services and policies through research that can have an impact in addressing cancer disparities. So our engagement structure, this is a broad outline of our engagement structure. And really at the core of our work with communities that we are working with in our catchment area, Latinx communities, Filipino, African-American, Korean, LGBT, rural South Asian, Pacific Islanders, we work directly with community leaders, patients in neighborhoods that we serve, faith-based organizations, promotoras, youth networks, coalitions, schools, FQHCs, federally qualified health centers. But in order for us to make this big impact, we really need the help and support of our entire system. And we're really fortunate to have the backing of our Cancer Center leadership, members within our different research programs who work with us to brainstorm, to see what types of research can address disparities. But we also have our Cedars-Sinai institutional leadership support, our medical network, our clinical trials office, our education and training programs, our health equity, diversity, and inclusion efforts, government relations, community benefit, and our fundraising department. And so in order for us to really catalyze research and address some of the issues that impact our communities in terms of health equity, we catalyze this through bidirectional engagement. So a lot of our leaders are really part of, and researchers are part of our community outreach efforts. Now, our community outreach team really represents the community. We are the community. We are LGBT, we are Korean, Latinx, Filipino, African-American, and we're recruiting more staff. We're actually recruiting African-American and other communities to collaborate with us. We also have a catchment area investigator who looks at community profiles and and characterizes populations within our catchment area that have disparities, so that we're able to look further and engage with the community to identify priorities that we can work on together. In addition to that, our staff also extends its reach through promotoras, community navigators, and nurses. We have a lot of Filipino nurses within our health system that support our efforts in the community. And then in rural areas like Antelope Valley, we've cultivated stakeholders that we bring to the table. Our catchment area is vast, and we coordinate with other cancer centers so that we're not duplicating efforts. So our catchment area meets the National Cancer Institute's criteria, and we serve, for example, Metro LA, the South Bay, West LA, San Fernando Valley, and Antelope Valley. And within our catchment area, really over 70% are comprised of the Latinx population. So we have a very large Latinx community, but we also look for disaggregated data where it's available. So data is scarce, but for example, Antelope Valley and the South Bay have large proportions of African Americans and larger than the overall proportion in the county. And again, in the South Bay, we have a very large proportion of Asian Americans and a relatively large community of Native Hawaiian and Pacific Islanders in the South Bay. So there's 2.3 million Latinx community members in our catchment area, and 70% are of Mexican ancestry. 21% are Central American. And then amongst Asian Americans, Filipino communities, Korean Americans make up about half of Asian Americans in our catchment area. And Filipinos make up the largest Asian American group in most spas except for Metro, where Korean Americans dominate, and in the West, where Chinese Americans are the largest. And then interestingly, South Asia, those of Asian Indian, Pakistani, Bangladeshi, and Sri Lankan ancestry are the second largest Asian American group in Antelope Valley and the West. We also have a slightly larger population of people who identify as LGBT compared to the overall county. And another interesting information is that the West also has a relatively large proportion of LGBT community members, 5.5%. But that is small compared to the percentage in Metro, which is 9.7% who identify as LGBT. And when it comes to cancer risk factors like tobacco smoking, obesity, alcohol use, we see that there are huge discrepancies amongst the different spas. And in LA County, we enjoy one of the lowest tobacco use in the US as a result of years of anti-tobacco campaigns and tobacco control work. But as you can see, some spas that are left behind, like Antelope Valley, still has a large percentage of current smokers. Obesity is another risk factor, and compared to the county percentage, there are higher percentage of people reporting that they are obese in Antelope Valley and South Bay. And there is alcohol use in the West Side, but similar to Antelope Valley, it has almost twice the percentage of people reporting heavy alcohol use compared to the county overall. And this is from the LA County Health Survey. So just to mention that we've started working with communities with cancer disparities, and I'll talk a little bit about the strategies we're using. But in working with the Latinx community, we realized that liver cancer rates have been steadily increasing, and this is probably due to the prevalence of obesity, and our experts are looking into this even further. But colorectal cancer is also the second most common cancer amongst the Latinx population. And amongst the Filipino community, compared to other groups, Filipinos have highest thyroid cancer rates, and the rates are increasing. And part of the increase may be due to changes in identifying and diagnosis, but because the increase we observed are still not leveling off, there may be other factors involved. In terms of with the Korean community, the rates of breast cancer, colorectal cancer have been increasing. And due to high smoking rates, lung cancer is also an issue amongst Koreans. And for all cancers combined, African Americans have the highest incidence rate amongst men and the third highest amongst women. African Americans have the highest rate of prostate cancer, highest risk for prostate cancer, pancreatic cancer, and lung cancer in men. And triple negative breast cancer, an aggressive type of breast cancer, disproportionately affects women of African origin. In terms of the LGBTQI population, this community experiences a myriad of health disparities. Both race and sexual orientation can be a source of stigma. So therefore, strategies to address intersectionality and intersectional identity is a really good approach to understand disparities. And I didn't have a lot of slides on data, but I wanted to mention that we have pulled all of this data together in fact sheets and profiles of all the different communities we serve. And we're happy to get this information out to everybody, and whoever's interested in, please send me an email. So in order to address disparities in the different communities that we work in, we really start with the community, and started with initiating dialogue in neighborhoods, with promotoras, with an LGBT advisory board, and pulled all of our networks together to form a community advisory board for our cancer center and our Cancer Research Center for Health Equity to promote bidirectional engagement. So the idea is that our investigators and researchers hear directly from the community. And so in the last couple of years, we've accessed community members to our researchers and helped develop quite a few partnerships in many of our different research programs. And I think our Cancer Research Center for Health Equity, we've engineered over 20 partnerships for research just in the last 2 years. And that has resulted in projects and proposals. But really, our approach has been to build the infrastructure first to provide services in neighborhoods and communities, and then engage our community leaders to really help us prioritize what their needs are. And that can then eventually turn into research studies. So this is the process that we use that I just mentioned, where we're sharing data, including geospatial mapping, which has been amazingly instrumental in helping us galvanize communities in different geographic areas because place matters. And then through a process with our stakeholders, we are then prioritizing the research. And we've organized town halls and advisory board meetings to really get our researchers and our community members engaged more closely. So this is an example of geospatial mapping that was developed by Dr. Lorraine Escobedo, who is part of our Cancer Research Center for Health Equity and our community outreach and engagement investigator. And really, this is a very old map of the density of late-stage breast cancers. And we identified Metro, for example, which is the bright red that lights up, as being an area of high need where there's a higher density or incidence of late-stage diagnosis. And the green dots are the Every Woman Counts clinics. So it's not like there aren't clinics in that area or providers. And so we realized that there was this huge gap that we had to address to see how we can, bring women to screening services, and really started looking at the system and institutions in the area to see what they're doing and what they're not doing. One thing that we also did is we worked with community leaders to conduct a survey, and indeed found that, for example, Korean women living in Koreatown that had the high incidence of delayed diagnosis, only 48.1% within the institutions that we worked with said that they were up to date with their mammography screening. And so one of the things we started doing is immediately identifying navigators who can connect the dots for members of the community, and really working with institutions to create systems changes so that women can access these services even more easily. So we launched our Health and Faith initiative because the communities that we wanted to reach, we were able to reach them on a regular basis through churches. And there were so many churches that reached Latinx communities, Korean communities, Filipino communities. And the Filipino community, we started out with a needs assessment. And so we're now finally launching outreach efforts in that community. But really in the Latinx community and the Korean community, we were able to get robust outreach, and we used CDC's community guide to identify evidence-based strategies so that they were rooted in evidence and that behavior change theories to help guide our work. And so, the work that we were doing is we were presenting workshops to community members that were in language, that were culturally tailored by community outreach coordinators that were from the community, and putting on cancer screening events in partnership with FQHCs so people have a medical home. And again, we were able to train over 32 navigators and promotoras and really have people connected to resources in these neighborhoods. And we were looking at, really local neighborhoods to implement these interventions and tap into the healthcare ecosystem. So this is an example of how we catalyzed research in the Korean community, where a lot of our efforts that we were implementing, from the data collection to sharing the data with breast cancer with the media, to screening events, through education programs, navigator training, and working with local clinics, we engaged our researchers throughout the process. And that really served as a catalyst to developing a research study to look at how all of this can impact and decrease breast cancer rates in the Korean community over time. And we have our Faith in Action church-based navigation model program that has been funded by the California Breast Cancer Research Program. It's a 3-year study. And similarly, we've been working in the LGBTQI community to also catalyze research by forming a community advisory board. And the board, because we realize how diverse this community is, and that, we don't have all the answers. We really need community leaders at the table. And that has helped us launch, for example, the Breast and Chest Community Forum, which was the first transgender and non-binary community forum to address this topic. We launched this in collaboration with the Susan G. Komen Foundation and the Susan Love Foundation as well. And other events like Let's Talk About Cervical Health for the transgender community were also organized. And in the LGBTQI community, our community advisory board was incredibly instrumental in giving us ideas of how to proceed in terms of outreach and engagement and developing a community infrastructure. So one of the things that we did was the community told us that if you really want to get the word out, you need to go to Pride events, but don't just go to West Hollywood Pride. And so we actually went to every single Pride in the city. There were 5 Prides that we went to and really got a lot of insight on, what communities are where, what are the intersectionalities. And they also gave us ideas on, the development of an HPV campaign, because we realized that HPV-related cancers were an issue in the LGBTQI community, although we don't have good, solid data. But we knew from focus groups we had conducted that many community members had not been vaccinated. So that was a campaign that we developed in collaboration with the Art Center College of Design. But they also told us something really important, that cancer screening guidelines were not inclusive of the LGBTQI community. So we developed a gender-neutral tool that uses the organ inventory. And so that is going to be currently tested under a research umbrella. Same with our HPV campaign. And this is what some of the images from the campaign look like. This campaign aims to normalize the conversation around talking about HPV and getting the HPV vaccine. And this was developed really through stakeholder engagement every step of the way. This is another one which came out of the community and really leverages this idea of pride, an act of self-love. And really, this is something that the community really resonated with the LGBTQI community. And if you look at the image, it doesn't have a gender, but it's really reaching out for support, to provide support. So I think this is a really important campaign that we're going to be launching next year as well. And as I mentioned, that we're launching our HPV campaign at Pride in 2022 in Long Beach. We're hoping that we'll be able to have an in-person Pride, and a lot of the campaign elements lend to Pride events. So we're able to use them and mobilize community members around it, including on social media as well. And we are developing this clearinghouse with a toolkit, a social media toolkit, to really be able to launch the campaign. We trained youth ambassadors, but we're expanding the youth ambassador program with training more youth ambassadors in the next few months, who will really help us improve vaccine uptake and provide navigation and wayfinding to youth to the right clinics. This is just the example of the gender-neutral cancer screening guidelines, and it really uses images that resonate with the community. We developed these in collaboration with members of the community, including the language that's used in it. Now, another map that I wanted to show was lung cancer in Los Angeles County. And Dr. Lorraine Escobedo mapped the higher density of late-stage diagnosis of lung cancer. And we find that there's, the impact is happening in South LA and Antelope Valley, where there's more African Americans. And so as a result of that, we launched our Healthy Lungs, Healthy Life initiative, really in collaboration with USC, Norris Cancer Center, and the Keck School of Medicine. And this initiative was funded by the California Community Foundation for 3 years. And through that, we were able to screen hundreds of African Americans who were eligible for lung cancer screening through FQHCs in South LA. And we're really looking into how can we sustain this effort through policy efforts. And so our Lung Cancer Coalition members and cancer survivors are working with us closely to look at policy initiatives to continue to provide this service. But a future direction that we're looking at is the development of a mobile LDCT screening program. And we're working very closely with a variety of different partners to see how that can happen in LA. In terms of working on clinical trials in the Latinx community, for now, we're providing a lot of education at the community level. So for example, we trained promotoras and activated them around this topic of clinical trials. And we have a really long way to go because there needs to be a lot more understanding and trust. And one thing that we did this last year is we brought the Every Woman Counts program to Cedars-Sinai, and this is the state's free mammography screening program for women who are underinsured, underserved, and uninsured. And so this is a way to be able to access women that we are working with in the neighborhoods and bring them to Cedars-Sinai. And I think over time, we can build the trust and create this infrastructure so women in the community have access to high quality care. So, our work has been predominantly in person in all the different communities. We really engage members of the community in our outreach so that we get individuals who are really informed about what needs to be talked about in the community, what the barriers are, and how to create the solutions. The answers are there, we're facilitators. And so, we did a lot of our work in person. And I'll get to what we then, how we pivoted when COVID hit. But these are, examples of what was done in the Korean community, in the Korean faith communities, at the various churches throughout the city. In the Latino community, we also worked with different churches and FQHCs, and also in the LGBTQI community. As I mentioned earlier, we went to prides all over the city and provided information on HPV and provided access to people to gender affirming care in the city through referrals. We also trained promotoras, and most of the promotoras that we trained worked in the Pico Westlake area and were really instrumental in connecting the dots for women. And the promotoras continued to work during the last year, and we supported the clinics with resources and funding as well. So just wanted to mention that, we immediately pivoted when COVID hit last year to develop a digital library and start translating messages in different languages so that we're able to get vital information to communities who need it the most and in language, because that information was scarce. And we also developed materials, we bridged materials. And one of the things our investigator, our catchment area investigator did is she identified neighborhoods that could have a higher, have the likelihood of having severe cases of COVID-19. And as a result, we started also targeting those neighborhoods for prevention. And we also got the information out to the community clinic association so that the healthcare infrastructure can also be a little bit more responsive. One of the efforts that we're working on as well is called Shine LA. And we talked about how place matters and that there's geographic areas where we really need to provide access to parks and other types of physical activity resources. And so Shine LA is really a multi-sector, multidisciplinary 10-year research study that is aligned with the city of LA to increase physical activity leading up to the 28 Olympics and the Paralympics. We had initiated this effort in 2019, but when COVID hit, it has been on hold. Parks were shut down and they're slowly opening back up again. And so we hope to resume our research components for this study. So I just want to end by saying that, we've been busy the last, 3 years and really getting information out to the community, linking people to screening, building capacity, training navigators, being part of coalitions and advisory boards, and forming community partnerships. And that we really were grateful for the support of our community partners who really, without whom we really couldn't do this work. And the other thing that we're grateful for is our institution helped us provide community grants this last year, which were aligned with some of the work we do, but also supported what communities needed during the time of COVID. So I want to end there and thank you very much for this opportunity, and I'm happy to take any questions.
Thank you so much, Zul. You and your team are doing amazing work, and we're honored that we get to collaborate with you on some of this work. So the first question I have is that you have a very diverse staff. Can you share your hiring and recruitment efforts?
Well, we are, I think it's more about experience and what experience people have in working with diverse communities. And even though, we have populations that represent certain communities, but I think that in terms of training, we all look at our work through the lens of intersectionality. So me being South Asian, being LGBT, being Muslim, But then also being a public health person, I'm really able to connect with a variety of different communities. And so really all of us work together on multiple projects, even though, you know, some people have more expertise, especially language access. And so I think it is, uh, I mean, we're very open and inclusive. So if somebody has the skill set, the interest, and the expertise, we're happy to include them in our team.
Thank you, Zul. Our next question is, what is your biggest challenge with outreach and what steps have you made to overcome these challenges?
Yeah, you know, our biggest challenge is that, you know, we can do education and we can improve knowledge, and we can link people to resources, but people have a lot of barriers to accessing the healthcare system. And I think that the biggest challenge is getting systems to change so that we are really able to serve the community better, right? So we've instituted, for example, language access at Cedars-Sinai, and we know that a lot of communities have transportation problems as well. And so these are things that we really need to think about, you know, when we're designing these programs and making sure that we have support from systems. And also, you know, looking at, for example, how do we capture this information, right? So for example, we don't really know, in a lot of clinics don't know, you know, what groups they're serving and they're not serving, especially people who are LGBT, because they're not collecting this data.
Yeah. So our next question is, where have you had the most success engaging the Korean community?
So we've actually used multi-level approaches to engaging the community, from working with community-based organizations to FQHCs that work with the Korean community, to the media. But I think our most success has come in churches, and really in our ability to reach the same people every Sunday, and, you know, be there with our messages. And in our community outreach coordinator, Dong Hee, has done a superb job of, you know, really organizing and mobilizing the Korean community, and then extending her reach through training navigators that then further take the message to our networks and reinforce it to the community networks and reinforce it even more, so that eventually people are able to access services and resources.
So I have one question, and I know this is very common in all our COE world, but, you know, it takes a lot of time and effort for us to build these relationships and build that trust. And we're also tasked with, you know, joining and matching our researchers with our community partners. So oftentimes that means handing off, and you're not sure how that relationship is going to work. So my question is kind of related to that, in the sense of, how do you rebuild trust if maybe something goes wrong, right? If something happens in that relationship, how do you rebuild that trust with a community partner with maybe they've had a bad experience at your organization?
Yeah, Myra, that's a really big challenge. And, you know, having worked in this area for so long, that does happen. But I think that I've been very adamant to be at the table to really, so I technically don't hand off my community relationships, and it does take a toll on me, but I just want to make sure that, you know, the community's needs are met, that there's adequate resources provided in the research collaboration, and that they're being heard, right? Because again, we really struggle with this idea of, you know, our communities really being invisible, and in the literature, in the research. And so it takes a lot of effort. And if I'm not available, then one of our community outreach coordinator is there, and we make sure that we're really tied to the process every step of the way. At least that's a process I'm using now. In the past, I've learned my lessons to just not hand it off, so.
Yeah, I know, it becomes personal, right? And which leads kind of to another issue, right? Sometimes the relationships we build we want them to build them with the organization, but they ended up being built with us, right, in our teams. And I think somebody asked, we keep forgetting we use the COE acronym, and that stands for Community Outreach and Engagement. We get lost in our world of acronyms. But how do we make sure that the relationship, isn't just with us, but also with the organization?
Yeah, and I think, I feel fortunate now that we have a lot of
I think you froze on us, Zul. Hopefully we get you back.
having their insights really can make a big difference. Sorry, I guess my internet's a little unstable, so.
Yeah, I don't think we heard the
Okay.
response to that question, if you don't mind repeating it.
Sure, I can repeat it. What I was going to say was that, we have, I feel fortunate that we have, researchers who understand community-based participatory research, who are from the community, who are diverse, and I think there's this big push from the National Cancer Institute to make sure that the research community, the scientific community is diverse, because they have, this deeper understanding of the needs of our community and building these relationships and building trust.
Absolutely. So we have a few more questions for you, Zul. The next question is, what are you looking for in a community partner, and how do you best engage with other organizations?
In the past, I thought, well, we should probably collaborate with folks who are like-minded, and I think that's still really important, and that there is this mutual benefit, and that there's capacity and resources on both sides to really develop something where we can have an impact. So, we think of our scope, our quality, and our impact of what we want to do, but at the same time, I've realized, for example, we develop partnerships with non-traditional partners like churches, and they've turned out to be the most significant partners. And so I think we just, having done this for a while, you realize that there may be little capacity, but the mission and their vision and their enthusiasm is there, and we can have this collective impact. And so it's important for us to bring additional resources to the table so that we're able to build the capacity of a partner. And really, this is how we landed the California Breast Cancer Research Program grant, is really through 2.5 years of working back and forth and building this infrastructure and supporting the needs of the organization when it didn't have the resources.
Yeah. And there's really no such thing as an organization too small, right? I think sometimes people think we're looking for a certain size or a certain group that you reach out to, but sometimes it's those small organizations that are really become the best community partners who are really willing to do the boots on the ground work. So definitely. Our next question is, does Cedars also make efforts to connect or bridge communities with one another?
Yeah, absolutely. So our networks and our funder, our networks that we formed, as you noticed, that we are we formed our community advisory board that really brings individuals from all of these different networks together. So our networks are comprised of probably 45 or 50 people, and we have 70 partners. And so the CAB that we have represents all of these networks. And so that's one way of, bridging communities with each other. But, in the past, we had a lot of infrastructure where people were able to, connect with one another. And so I think, this is of value, that if we can come together and revive that infrastructure, would be very useful.
And on that note, I think I have a new project for us, because one of the things we're not good at is, how do we measure that, right? How do we measure these connections that we create by putting those groups together? I know, for example, some of our groups have been able to join together and apply for grants, or, they invite each other to put on events, or, there's just so much networking that goes on in doing policy. And it's so hard for us to capture that. And it really begun probably because of like your tab or, whatever that is. So really, I think it's another great project for us to learn how to capture that. And what is it that everybody who participates in these community engagement and outreach efforts, what they gain and how they network. So it's like a whole social networking that we really need to take a deeper dive into, I think. So, but again, adding more to your plate, Zul.
I'll reach out to you for help on that one.
I know, right? You say it, you have to do it. So our next question is, are there certain tactics that you would recommend for an organization to build trust with an underserved community?
Yeah, you have to. I mean, it's all about keeping your word and delivering and being authentic and, making sure that you keep the mission and the vision front and center of what you want to achieve together. And, there are going to be hiccups and challenges and, people leave, there's turnover. But I think, just being committed to what you started is one way of building trust. It's a give and take, right? So I think that is just this, it's a simple way of putting it. But I think, there's also the formal aspect of developing the partnership and the relationship and having the MOU and making sure that, each side puts in what they're interested in achieving and what their resources are in coming through for one another.
So, another question came in, and it says, I'm with this Cancer Support Community affiliate. To answer the race ethnic background question in our registration form, one new member indicated others and put Middle Eastern in parentheses. Sure enough, we did not have a Middle Eastern option. What race or ethnic options do you use in your research?
So, I just spoke to our Office of Research Compliance that has, we just had this conversation today, Dr. Lorena Escobedo and I, and, we really have started, and a lot of this work, I think I mentioned this earlier, came out of our community outreach and engagement efforts because, we've been working with the community. I worked with the Armenian community as well for years. And when we looked at the forms, Armenian was not listed as a category. And Armenians don't identify, some Armenians may not identify as Middle Eastern, right? So, I think that our research, Office of Research Compliance and just the research enterprise has really started including all of these demographic components. And even with the South Asian community, it's not just Asian Indian, it is Pakistani, Bangladeshi, Nepali. So, I think this is going to have to be an ongoing dialogue that we have with people who are developing the forms and are collecting the data that, again, it's incumbent upon us to disaggregate the data because otherwise we're masking disparities. So, should be a common practice that if you really want to know who's impacted the most, you have to disaggregate the data. Otherwise, you just can't see it.
Yeah, I think as COE people, we've never really worked in that health informatics field, and it's something new for us, but it's something we have to work in, right? How are we collecting the data? What is the data that we're collecting? How is that data used and disaggregated? But in order to meet our community needs, we have to know what they are. And like you said, it could be hiding, some really important information if we don't disaggregate that data. So it's definitely important. So yeah, I guess I'm going to have to go back to school again and learn a little bit more about health informatics so I know what we're talking about, right? So another question for you, Zul, again, with community outreach and engagement, is in terms of the policy aspect, right? And so our job is to, create this information, create these programs, and this address these needs. But what do you suggest for, average person to do in terms of advancing health policy?
Yeah, and I think that for those of us who worked in tobacco control, we know that back in the day, look at what it resulted in, right? We really organized communities, but we really used data from the communities to take it to policymakers and say, look, 70% of people really want no smoking in restaurants. So, I think, and if you want people's votes, you're going to have to look at this research. So I think bridging the research to policymakers is really where we can get really big results. When I look at the late stage diagnosis amongst African Americans in South LA and Antelope Valley, I mean, to me, this is really an area that we can bridge this research with policymakers and see, where we can make a dent. So it's very difficult, but I think that there's a lot of groups that are doing amazing work, like the American Cancer Society and ACS CAN. So, we have a lot of allies, but I think we can take this research to ACS, to a lot of these voluntary organizations who can help us create this impact.
Yeah, thank you so much. Yeah, because it is the work, hard work and long-term work, as we can tell from tobacco, right? It didn't happen overnight. And we definitely need those grassroots efforts and the voices of the community to be heard by our policymakers in order to advance that policy and actually make a lasting impact. Now, I have another question for you, Zul. And I mean, in COE, we have no problem collaborating. I mean, it's in our nature, that's what we do, but we have a lot of cancer centers in Los Angeles, right? We have a lot of overlapping catchment areas. And so, the business model is a little bit more protective of those areas in terms of, who gets to work. So internally, how do you overcome that when your work is collaborative? And perhaps there might be, some, barriers there in leadership who maybe don't want to be as collaborative with other cancer centers.
Honestly, I've not really encountered that. I think, as you remember, like once I joined Cedars, I reached out to everybody and said, why don't we work together? And we're now working statewide together, and we're working on a national level together. So I think that, but yeah, I see your point. But again, the needs of the community, I feel, should dictate the way we approach our work in COE, right? And where the disparities are, and partnering on research, on outreach, on policy, especially policy, So I think we can be the change makers. The COE teams can, demonstrate how this is really important for our communities and for LA. And, I mean, the disparities in LA are so huge, right? Because LA is more populous than 23, states. So we need more cancer centers in LA, and we need more collaboration in LA. So.
Yeah, all that pressure to be the role models, right, of how collaboration is done. But you're absolutely right in that, LA is so large that there's no choice but to collaborate. None of us can reach, 10 million people on our own, which, is the size of our county. And so it's really important to do that. And we also don't want to have to reinvent the wheel, right? If one of us is doing something that's successful, that then the other one can tailor more to another group. I mean, that's the whole point of collaboration. And that's the whole point of research, right? Is that you're trying to build these evidence-based models, whether it's in clinical care or, out in the community. And that's really what we want to do. So I have another question that came in for you, Zul, and it's asking, what are your outreach goals as you return to more in-person events?
Yeah, I think we're actually beginning to start with assessments first, talking to our community leaders and the pastors that we've worked with in churches. And I just went to a church last Sunday and had a great conversation. And, a lot of the pastors are telling us that people are still scared to come out and, attend service. And so we are continuing our virtual education, but really because of delayed screening, really making a big push to get people into screening, because a lot of people have not just, put off their screening, but they're getting comfortable not getting screened. So I think that's the danger of it. So we really have to agitate community members, but also rethink, what have we learned during COVID that has been successful, and how do we, continue to use those approaches? Like, one thing that we did is we started just training community leaders and navigators, and we said, look, you guys have incredible reach. Why don't you do this work and keep it going? And, let's work together to organize events in these neighborhoods for screening. So, we're just continuing to activate networks, in neighborhoods, but kind of listening to what our community leaders are telling us, that, it's a little bit too soon to do in person.
Yeah, I think, of course, being respectful of what they need, and making sure that, we're listening to our community leaders. Now, one more question for you, Zul, and this has to do with what COVID has highlighted, and that's the spread of misinformation, right? I mean, we're selling prevention, which has always been difficult to sell. Try to get people to go get screened when they're feeling okay. It's easier to go when you're feeling symptoms, or something, you think something is wrong. But selling it when you're just fine, especially when there's all these barriers, has been difficult. Now we have an extra added barrier of battling misinformation. So do you have any tips or tricks or things that you and your team are doing to help battle misinformation in the community?
Yeah, I think so. Something that we've done in the Korean community is to teach community members how to seek high quality information that is science-based, that is, so for example, when we did this throughout our trainings, where we talked about, look, if you have any question about cancer, because we know cancer is so complicated and that there's so many myths out there about cancer, and we possibly, as outreach individuals, are really not trained to provide advice to people on specific issues. And so we've actually bridged people to the National Cancer Institute's Cancer Information Service. And that, that service is available through phone in English and Spanish, and, and that there's online information that we can use to help people adapt it in their own languages. So that's how, like, our Cancer 101 was born in Korean, where we just started taking what's already been done that's science-based, and then linking people and teaching them, the skills to seek out high quality information, so they're empowered.
Yes, thank you so much. So yeah, I know definitely making sure that people understand what is a credible source, right? And I know we started it back in the 2016 election, where you were having, where the emergence of fake news. And so making sure that people understand what is a credible source of information, and then how do you access those credible sources. And I mean, it's an uphill battle, because we know misinformation travels 8 times faster than facts. And, when social media, it spreads so quickly. But definitely those are some great tips. So I really want to thank you, Zul, for sharing the wonderful work that you and your team are doing. And, we're glad that we're able to partner with you and, learn from you as well, and be able to leverage some of those resources and programs that you're putting into the LA community to meet our community needs. So thank you so much, Zul. And so if anybody else has any questions, I'm sure they can reach out to you, right, Zul?
Absolutely. And thank you so much for the invitation. And again, I look forward to our continued collaboration and partnership.
Thank you, Zul. And now what I'd like to do is go ahead and reintroduce Julia Forth. Julia Forth is the Cancer Support Community Los Angeles CEO. So she's going to come back and close us out. So welcome back, Julia.
Thank you so much, Myra. And really a big thank you to Myra. She was just wonderful. Thank you to City of Hope for allowing us to have Myra all day long to host this event. She was just amazing. And I want to thank you all for being here today. It was an incredible day. I know I said wow many times. I did not know that. So I learned a lot. I hope you learned a lot. And just quickly, I want to thank the staff, the board of directors, our professional advisory board, and our Cancer Equity and Diversity Committee. Thank you to our sponsors, Kite, a Gilead company, Union Bank, UCLA Health, Johnson Comprehensive Cancer Center, CGen, and Cedars-Sinai. Thank you also to our speakers, Natalie Burke, Dr. Shannon LaCava, Dr. Kimlin Tam Ashing, Julia Applegate, Dr. Hayes Bautista, and Zul Surani, and our additional roundtable discussants, Kim Hammer, Anna Rocha, and Sophia Sharp Donaldson. If you are here for CE credits, don't forget to fill out your evaluations so you can get that certificate. And of course, reach out to us at our info account if you have any questions, info@cancersupportla.org. Those wonderful speaker slide presentations will be, and recordings, the recordings of the event will be available and posted on our website in the coming week. So look for that at cancersupportla.org. As Zul Surani of Cedars just said, to do this work, you need to be committed to what you started, and we are committed to what we started here, and we will continue our work. And thank you so much for being here today. Have a great rest of your day and evening.